We are preparing midwives to work across the scope of practice. They want to work in continuity of care models. There are a few in Australia who work in midwife-led continuity of care models. So I wanted to find out what their experiences were and describe what support systems were available and what helps them transition. So this is a qualitative descriptive research project. I wanted to find out about their experiences, and it was set in New South Wales. Remembering there's all different funding systems in each little box there. New South Wales, I found 9 new graduates. And I'll just put this in to let you know. Out of those 9, I probably knew 5 or 6 of them because it's very small and because I've worked in the area for a long time, but I taught them as well. And that was something to think about when collecting the data is, are they saying what I think they want me to hear because they know me? Northern Territory, Darwin, there was one up there and she worked with Indigenous women in the community mostly, their antenatal and postnatal care. In Darwin, they have to come and give birth in the hospital because she was out rural. So they actually asked the women to go into the hospital at 36 weeks, which is actually opposed to their culture. It's not culturally safe because Aboriginal and Torres Strait Islander women would like to give birth on country. It's very important to them. And just so you get this, the Darwin Hospital, you can see where it is, it's right up there in the tropics, was modelled on the Canberra Hospital, which is where the snowfields are. So the Darwin Hospital is modelled exactly the same. It has snow eaves, and there's no snow up there. It's tropical. It's near Papua New Guinea. It's near the Torres Strait. So the women actually have to go up in the elevator to the birthing room. So not only are they removed from their homes and their families and can't birth on country, they have to go in an elevator, which they don't like because they like to have their feet on the ground and give birth upstairs. So one midwife worked there, one new graduate, one worked in Alice Springs. Those two knew each other. So the sampling method, I went out looking for new graduates who work in continuity of care models, which was really hard. I couldn't really find any. And then when I did speak to one, they'd say, oh, you know, my friend, she was in my year, she's working in Alice, you should call her. So I did. So it turned from purposive sampling to snowball sampling, trying to find people. And I had to change the criteria from just in their first year of practice to their first or second year of practice, because out of the 9 in New South Wales, some of them started the transition to professional practice program, and part of that program was to rotate them into a continuity of care model, and they stayed in the model. They didn't come out again, but they were the second year by the time I talked to them, only just. So that was difficult. So I only found 13, and we estimated that was about half of all the new graduates in Australia. Small number, the age was quite varied. 12 came from the Bachelor of Midwifery, so the direct entry, and only 1 was a nurse who became a midwife. We had university ethics approval, and I did semi-structured interviews. Mostly the New South Wales ones, except for the Broken Hill woman, were face-to-face. The others were by Skype, which wasn't great, and we have time differences in Australia as well, and telephone. So there was some open-ended questions to guide the interview, to collect the data. Then I transcribed some of the interviews, and I also paid for some professional transcription after I was spending so much time transcribing. But it helps you in the thematic analysis, which I did, and what I found from the data was the new graduates found it easier to work in midwifery-led continuity of care models because they developed a relationship with the woman, they got to know the woman, and a relationship with the midwives who they worked alongside because they were small groups. So then I applied a theoretical framework and did further analysis, which is the continuity of care. So this is the first definition and measurement of continuity of care, which was by John Saltz, and he is a physician. So it's not just midwifery, but it's about continuity. Informational is just where the person has notes about them, medical records that go between different care providers. Mostly I think our setting would be longitudinal, where the person has a medical home, a hospital, but she will see different care providers throughout her pregnancy, different midwives. She doesn't know who's going to be there for the birth, and different midwives in the postnatal period. Interpersonal continuity or relational continuity is what I found was what developed in my research, is that the midwives developed a relationship of trust with the women and the women with the midwives. It was reciprocal, and they found the trusting relationship with a small group of midwives. So these are some of the quotes from what the participants said. The relationship with the woman is, as I get to know the woman, they get better care. I mean, I don't need to read quotes. You can read them. Can you read them at the back, Andrew? But the satisfaction that the women got and the satisfaction that the midwives got, and they liked using all their skills. There was a big theme about consolidating skills, that they consolidated skills better when they knew the woman and they knew her history. And not only that, they do antenatal care in the morning, they might be on call for a birth that night, and then they do postnatal visits the next day. So they were constantly using all their skills. And the other arm of results was relationship with the group. And they all had mobile phones, so they used to say, I'd just call them if I didn't know what to do, I'd just call one of the group. Or they were always there, I'd send them a text, or every morning they'd send me a text and say, how's your day looking? And there was a lot of support from the group. And part of that was the midwives who worked in the group, they didn't want the model to disappear. So it was like protecting the model. They wanted midwifery care in this way to continue. They knew if they didn't have the new graduates, it might disappear. There'd be no midwives to do the job. And they felt that they were prepared from their degree, from doing the continuity of care experiences in their degree. And they felt like a real midwife when they worked like this. So this is the framework, interpersonal continuity of care, and there's the findings. So the relationship with the woman, finding satisfaction through continuity, consolidating skills, finding confidence. That's the other thing for new graduates is important, the confidence. Having trusting relationships. Oh, this is really important, defining professional boundaries. So they developed a relationship of trust with the woman, and then they found it hard to end the relationship. And some of them would say, oh, she's coming to my wedding, and it's like, oh, okay. So you ended that well. Yeah. They struggled actually with that. I think there's one quote that says they're not your friends, I'm your carer. And they felt supported from within the group. They wanted to sustain the model, and they felt prepared, and that made them all feel like becoming a real midwife, especially those ones who'd already started in the transition to professional practice program. They said working in continuity made them feel more like a real midwife. And that's published, if you're interested in midwifery. Further analysis of the support from the group, because that's one of the arguments to ask new graduates to go into the transition to professional practice program, is that they will get support from the hospital. But actually they found mentors and they were well supported in this model. So there's no argument against it, is that they're quite well supported. So that's published as well, the mentoring experiences. So what's wrong with it then? Okay, why is there only, in that huge country, only 13 new graduates working in midwifery continuity of care that I could find? And I looked hard, and how do women get into continuity of care models if there's not enough staff, and why aren't midwives transitioning straight into these models? So then they came up with the next question, which I called phase 2 of the research, is what are the experience of managers and other key stakeholders when they employ new graduate midwives? So the other key stakeholders were educators, clinical support midwives, the clinical educators in the wards, those sorts of people. So So I decided to go and talk to them. So I did the same thing. I did a qualitative descriptive approach, and I found them from varying places. So Queensland's quite progressive in continuity of care. That's probably one state where more women get it than other states, and it has to do with the funding, and also that the midwives, those privately practicing midwives, have access to public hospitals. There's only one public hospital in New South Wales that allows privately practicing midwives to access their services. So 1 in Queensland, 11 in New South Wales, 1 in ACT, Australian Capital Territory. There were 2 midwives from there, we've got to say, 2 new grads down there. Victoria, Melbourne, yeah, and South Australia, 1. So I had to, how I did that was I Googled maternity services that offer continuity of care, and I contacted their managers, and then I asked them, do you employ new graduate midwives? And interestingly, I found 15 and 12 did employ them, but 3 did not. And I thought, well, that's good, because I actually want to hear their perspective. What is wrong with this? So I had to go back to the ethics and ask for that. And I did semi-structured interviews. They were all conducted by telephone because managers are very busy people. So I couldn't actually get a slot to come and see them. Some of them I wouldn't have been able to see, but they all wanted to do it on the phone. And that was good, because if I rang them and they couldn't do it now, they'd say, can you ring me back this afternoon? So that was better for them. You do miss stuff though, and you also get, oh, I've got to go now, I'll call you back, so it gets interrupted. There was some problems with doing telephone interviews. I did some of the transcribing and sent some of it away, and then did thematic analysis, and then the themes that started to come out was, this is new, this is innovative, we're so clever and we're going to make this work. So I found a theoretical framework to look at the themes through, which is the diffusion of innovation theory, which Rogers first developed in 1962, but Trish Greenhalgh, don't look at this, it's very busy, I'm going to talk you through it, developed a conceptual model for considering the determinants of diffusion, dissemination and implementation of innovations in health service delivery. So that's why I thought it was important. So this is in public hospitals throughout Australia, where they're putting new graduates who are the innovation into, even midwifery continuity of care is an innovative, and it's a complex intervention to move midwives off rostered shift pattern and to have them working flexibly and on call, and you don't know where they are as a manager, is a complex innovation. So it's just about having resources, knowledge purveyors and change agencies. So those managers who did employ them, I see them as change agents actually, disseminating it to the organisation and diffusing it into the organisation. So there has to be some things in the system already for it. So they have to want to start continuity of care models, they want to staff them, they have to have enough supports for the new graduates, they have to have enough clinical support midwives or educators around. Then it has to be adopted. So the core staff have to welcome new graduates into the labour ward, for example, when they come in with the women. And the implementation then goes smoothly. The consequences of that, if something happens, it's going to feed back and it might disrupt the whole diffusion of innovation. So that's what I used. And what I found is that there are drivers, enablers, facilitators and barriers to employing new graduates into midwifery continuity of care. Mostly the driver was, we need to staff the models. I need to provide this, the government says I have to do it, we're getting funding for it, I need to staff them, so we need to recruit for the future. They recognise they're registered midwives, they're allowed to practice in this way, as per the ICM definition. And they have to prepare students and recruit new graduates. Many of the managers would see a student they thought would be good in a model, and they'd go up and say, would you like to work in this model at the time of graduation? And the other thing that they did was when the students had experience with the group practices, the midwives would say, do you want to work here? So-and-so's pregnant. Just cover her maternity leave and then, you'll get in that way. So there was a lot of that going on. They recognise they need support. So often they would say, right, you're going to be buddied, you two will work together. But the most important thing I think they did was that they gave them a longer orientation period, and they gave them a reduced caseload to begin with until they found their feet. And then once after 2 or 3 months, they were up to speed with the rest of the group. And they had to manage myths. So there was a lot of, it's not safe, mothers and babies will die, mothers and babies die in private hospitals with private obstetricians. So if that's going to happen, there's something else that needs looking at. It's not necessarily the care provider from a new graduate. So that's the model I came up with, the driver, enabler, and they all feed each other, and the innovations, new graduates working in midwifery continuity of care. And what I found is it was visionary leaders that were able to enable this to happen. So visionary leaders said, right, we can do this, we're going to go ahead and do it. And they faced quite a lot of opposition from people, quite a lot of barriers. And that's published there. So this is my final chapter, is a model that will enable new graduates, because it's like a recipe. I want it to be repeated. If you do these essential components, then you should be able to employ new graduate midwives straight into continuity of care models, and hopefully the women will have more access to continuity of care as they expand, and they're supposed to expand. It's government recommendations, and they're being given timeframes to introduce them. So relationship of trust is that if it is one-to-one with the woman, the higher the continuity, the level of continuity, the relationship, the higher the trust, and also the smaller the group of midwives. It doesn't work if you have 8 to 10 midwives. You need to have 4 midwives to 6 midwives maximum. So support from the small group and mentors. My research found that some of the managers allocated mentors, but others let the midwives find their own, and they all did. They all had a mentor, either within the group. Occasionally, if someone wasn't available in the group, or they couldn't find one, they'd find one outside the group, but that was rare. Well prepared, so we need to keep, education needs to keep the continuity of care experiences in the curriculum. And team meetings, they had team meetings regularly, usually weekly or fortnightly, and in those team meetings they have designated obstetricians that they collaborate with. So that was really useful for them. They then developed relationships of trust with the obstetrician. So they would say, oh, that doctor, he knows me. So when I go and talk to him, it's fine, he trusts me. Because there's a little bit of a barrier from the medical profession. But most of the time they don't know, they're new graduates, so it's not really a problem. An approachable, available manager, educator, or clinical support midwife. So that meant they went to the meetings or they met with the new graduates. And they were visionary leaders. So the managers have responsibilities on this side and the new graduates have responsibilities. Students have to seek out continuity. They have to practice in that way. They have to want to practice in that way. They have to find and access mentoring. And they have to develop professional relationships. Otherwise, they will burn out if they are becoming really good friends with the 40 women they're caring for a year. And engage in reflective practice with the group. And the managers have to address organisational culture. And the culture is about that new graduates should do a year on the wards before they work in. As soon as they finish that year, they're like, oh, you need to come and work in the group practice now. It's like, they can do it straight from, and seek out students to work. Okay, that's it. 44, 43.